Okay, I think we're ready to start. It's a real pleasure for me today to introduce Dr. Ros Vallings to you. Ros is one of New Zealand's leading authorities on chronic fatigue syndrome in New Zealand, with over 35 years' experience in the field. She's a doctor, medical doctor, educator, author, researcher and speaker. She's the author of the book Diagnosis and Management of Chronic Fatigue Syndrome, ME, and was awarded the New Zealand Order of Merit in the 2008 New Year's Honours. She served as President and Medical Advisor for the New Zealand Myalgic Encephalopathy Society and is a board member, secretary and member of the editorial board for the International Association for CFS ME. She's also been involved in developing guidelines for the diagnosis and management of CFS ME in New Zealand, is co-author of the Physicians Primer and participated in the international group producing the Canadian and international consensus definitions for CFS ME. Ros has also been involved in GP and student education at the University of Auckland, regularly speaks to medical groups around New Zealand, and has presented numerous papers at international conferences. So without any further ado, I'll hand over to you, Ros. Thank you.
Oh, that's not working. Is that working now? Yes. Good, good. Okay, well, if by chance the sound fades, please just put up your hands or let me know in some way. But we're going to talk about chronic fatigue syndrome, otherwise known as ME, myalgic encephalomyelitis or encephalomyelopathy. Wherever you happen to live, you call it something different. But that's what we're going to talk about today. And I'll probably buzz through these pictures fairly quickly because we have limited time, but hopefully a little bit of time for possible questions at the end anyway. People with this illness are tired all the time, and the beached whale is probably very indicative of how many people with this illness do feel a lot of the time. So first of all, we need to say, well, what do we mean by fatigue? And fatigue is something I'm sure all of us here are aware of because, it's a common problem. People get tired all the time for various reasons, but it's the commonest symptom seen in any GP consultation. And I think most illnesses are associated with a certain amount of fatigue. And we have what we call normal fatigue, which most of us will experience at the end of the day or if we've had a late night. And then you have disease-related fatigue due to various medical conditions. Even the common cold, people feel terribly tired. But the tiredness in chronic fatigue syndrome is very different. It's unrelieved by rest, so a night's sleep doesn't fix it. Exercise worsens it, whereas people who are very depressed and often very tired find that exercise really helps them a great deal. And there's often a really slow recovery from any activity or exercise, and they call that post-exertional malaise. And then just looking at what the incidence of chronic fatigue syndrome, approximately worldwide 4 per 1,000, and that's been now looked at in many countries, even some of the third world countries, and it would be very hard to diagnose in places like that, but studies have been done, and that equates to about 1 million in the United States, probably about 18 to 20,000 people here in New Zealand, 66 in Australia, and it affects all ages, all types of people. Doesn't matter whether you're male, female, Christian, Muslim, educated, uneducated, and so on. It's throughout the world probably fairly even. And just to give you a little quick insight into what the illness actually is or how it starts, usually, almost always, we'll start with what we call an acute episode, something like an attack of flu or glandular fever, usually a viral type of illness, and you get a surge of immune activation when your immune system fires into action to kill the bugs, and that's what we hope and expect, and that's usually what most of us will experience. And at that time you get probably fever, glands up, fatigue, achy muscles, the typical symptoms of a viral illness. And then gradually the immune surge begins to die down, and in most people, about 90% after any viral illness, symptoms will all be over and things have quietened down after about a month. There will be a slower group, and I'll explain the wavy line in a minute, about another 9% who take about 6 months to recover, and we call that post-viral syndrome, post-viral, post-infectious syndrome. And then there will be this 1% who go on and on and on and on. And this is typical after, as I've said, their glandular fever. So you don't get 1% going on and on after the common cold, but certainly after glandular fever, about 1% continue to be unwell and take a very long time for recovery. And at around the sort of 3 to 6 month phase, we start thinking, is this perhaps chronic fatigue syndrome? Is this a different group? And the wavy line really is indicative of the fact that as people are slowly recovering, they will get surges of immune activity due to some sort of physical or mental stress on the body. That may be pushing the exercise too hard, or a sudden major emotional stress or something like that, and you get a surge of symptoms. So that's what's happening. And these are the sort of people who will often get it. I mean, not just athletes, but certainly athletes and high-achieving people tend to be more prone to the illness than the couch potatoes, who probably lay around after their infectious episode and recover more readily, whereas the person who keeps trying to get going is a little bit more vulnerable. And these are the sorts of issues that predispose to the illness. They've identified 8 potential subcategories of the illness genetically. There was almost always some sort of viral onset, though there will be some people whose illness might have started with an accident or an operation or a major stressful event. But there's almost always stress of some sort in the lead up. I think 88% of sufferers in one big study were found to have either mental or physical stress in the lead up. There will often be a sleep deficit history, and certainly mothers of new babies who are unfortunately woken up all night, and airline personnel with time zone changes. These sort of people tend to be very vulnerable. And when I say sex, I don't mean that having sex puts you at risk. It's actually the fact that more women than men seem to get it. And there does tend to be the personality type of the get up and go high achiever, but not always, not always. None of those things are set in stone. And they have identified, as I say, a number of genes that make one vulnerable. The genes don't mean that you're definitely going to get the illness, but you just inherit a vulnerability, as we perhaps inherit a vulnerability to thousands of other diseases too. And almost always, as I say, there will be a viral onset, and these are some of the viruses that we frequently see cropping up, particularly viruses associated with the herpes family, and HHV6 is one of them that has been commonly found to be a lead-in, and Epstein-Barr virus that causes glandular fever. And these enteroviruses have been talked a lot about by a particular researcher called John Chia in California. He's looked at them and found that a high percentage of patients who have a lot of irritable bowel symptoms associated with the illness are actually carrying an enterovirus in their gastrointestinal tract. All very much still in the research pipeline, but pretty exciting stuff, really. I won't go through this in detail because of constraints of time, but there have been identified quite a few changes in the immune system, and they're finding new ones all the time, of things that are going on in the background, and we don't know if these are just associated with this illness or just, maybe happening in lots of other illnesses too. But all the time they're beginning to come up with things that seem to be pretty consistent. And Nancy Klimas and her group have noticed or identified a lot of changes in the cytokines, which are the immune chemicals, all part of your fighting force. And I think the interesting one at recent conferences has been increase in this particular substance called leptin, which is actually produced from our fat cells and also increased during stress. But particularly they have found higher levels than expected in this illness. So all these things gradually are bringing us closer to potentially finding some sort of biomarker which will make diagnosis a lot easier. I think it's fair to say that the severity of the illness depends on what we call the immune cascade, the changes in the immune system, and the symptoms generally are due to immune activity, they think. Things like fever and enlarged lymph glands, sore throats, all shown to be signs of immune activity. And the symptoms particularly are many and varied, and I won't be going into them all today, but particularly large numbers of people suffer from what we call orthostatic intolerance, which is due to generally low blood pressure, so that if you're lying down and you stand up suddenly, you feel very woozy, or if you stand for any length of time, you know, people stand in the hot sun and they begin to feel faint or even faint, and those symptoms are very, very common. And probably mainly due to a combination of low blood pressure, which may be due to low blood volume. David Bell in the States has done quite a lot of studies looking at that. These other things that I've mentioned here, poor perfusion of the brain, the brain is perhaps lacking in oxygenation and not fully functional, so people have a lot of cognitive problems, and even the extremities that feel very cold often, and muscle weakness and muscle fatigue are very, very common too. Slow gastric emptying, you find many times people will complain of bloatedness and not able to digest food very quickly, so that everything's very slow, and they feel symptoms which are often diagnosed as irritable bowel syndrome, but are in fact due to just an overloading of the gastrointestinal tract. And so people often do well with much smaller meals, small frequent meals and so on. Lots of brain abnormalities being found, and particularly the cognitive impairment is a big, big symptom. And many people will say, well, the one reason I can't work is because I cannot predict how my brain will function on that day. And people will be very mentally foggy very easily. They have memory problems. They'll often say things like, I feel I'm getting dementia. But fortunately, the brain changes are not permanent. They're very transient. And the people who recover have no evidence of residual brain deficits. So there's a lot of stuff going on in the brain. And there are some neuroendocrine problems as well, and just a few of them listed there. Certainly, when you do blood tests on people with this illness, there's often very little showing up, but their cortisol levels are often low, and some of their other hormone levels are low, particularly if we do these tests in the morning. And this is thought to relate to their sleep deficit, which we're going to come to in a minute, but certainly they do have problems with sleep, not enough deep level 4 sleep, so they don't produce their hormones properly. I mean, that may apply to other illnesses too. And then most people with CFS do suffer from what we call fibromyalgia, and most people with fibromyalgia actually do fit the criteria for a diagnosis of chronic fatigue syndrome, so there's a great overlap there. And Mike Butler in Auckland has done a lot of work looking at the reasons why some people suffer from fibromyalgia, which is an increased sensitivity to pain, and they know for sure now that there are chemical changes in the central nervous system which alter one's perception of pain, and so these people do have different pain sensation and feel pain far more intensely than the non-sufferer. And this leads to various, again, many symptoms are associated: gut problems, headaches, certainly musculoskeletal problems, and so on. And I've listed there a few of the research findings that go hand in hand with all this. Now, we make a diagnosis using various sets of criteria, and the CDC criteria were the ones that were laid down originally, probably 20 odd years ago now, to make a diagnosis, and a team of people got together and set up a set of criteria. And for anyone who's really interested in wanting to know more about this, there's some very good books over there which you're welcome to take, booklets about making a diagnosis and that kind of thing. So this was the original set of criteria, and you had to have 4 or more of this set of symptoms which had lasted for 6 months or more. And that was a fairly inclusive set of criteria, and does actually diagnose most people reasonably accurately, and it's still the set of criteria being used in most of the research around the world. However, we've been through various updates of criteria since then, and this set of criteria, which is a couple of years old now, since it was sort of set down, includes some extra symptoms or extra things which are not included in that original criteria set. So we now have included a need for some of these things to have been present: post-exertional neuroimmune exhaustion, which is like totally exhausted after you've done exercise, the orthostatic intolerance. Most people are alcohol or drug intolerant. They can only cope with many amounts, and it goes so far as to say now that if a person can tolerate 2 or more drinks of alcohol, they probably haven't got chronic fatigue syndrome. And that's a fairly firm statement that's coming out from some of the current research. So although that's not a diagnostic test, it gives us a feel when we're taking people's history of whether we're on the right track. And there's quite a lot of work now going on looking at some of the pediatric issues. Making a diagnosis in children is really hard because some of these kids have had it from very young age, and they can't remember what it's like to feel normal, so they don't think they're suffering from anything. So making a diagnosis in children is very hard, but I'm part of a group internationally now. We're setting up a set of criteria focused very much on pediatrics, updating the current criteria for them. So what happens? You go off for laboratory testing. Hardly anything ever shows up as being abnormal, but we're really looking to exclude other illnesses. It's kind of like a detective trail, and you gradually get closer and closer to forming that diagnosis and feeling you're on the right track. So you need to do the full blood screen, and then if a person has particular symptoms which are a little bit different or don't quite fit, we do more specific testing. For example, chest pain's quite common in this illness. It's often nothing to do with the heart, but we need to do ECG to make sure the heart is healthy. Or if the person has a cough, we do a chest x-ray and so on. So you do your routine stuff, and then you expand it to try and make sure you're really on the right track. Because obviously with any diagnosis, if we haven't got the right diagnosis, of course, how are we going to treat it correctly? And that's the key, really, isn't it? So as they said many years ago when this was first being talked about, most of your tests are normal, it could be ME, and I think that still holds in many ways, not absolutely, but it's not a bad thing to remember that tests generally are normal. And there's a whole list which goes on and on and on, and probably I could cover about 6 slides with all the possible differential diagnoses, but those are just some of the things we're looking at. Lupus, polymyalgia, certainly things like depression, anxiety, bipolar disorder, where there's an up and downing of symptoms, and sleep disorders commonly come into it. And you find as you begin to work your way through the diagnostic process that a number of people will be eliminated from the CFS diagnosis because they've got some of these sorts of things. Ehlers-Danlos syndrome is an interesting one. It's very rare, but it's very, very similar, and it's an inherited disease where people have a loss of elasticity in their muscles and joints, and they have orthostatic intolerance and lots of the symptoms, and it can come on often, usually gradually, but you know, a person who has been perfectly all right up until it comes on. So that's the sort of thing we have to kind of sort out a bit, really. And I think it's fair to say that we cannot make a diagnosis of chronic fatigue syndrome in the presence of untreated depression. So when people come to the surgery to see someone like me and they are obviously depressed, or we think they might be depressed, we have to persuade them that yes, you do need to have this depression treated, you need antidepressants, we cannot diagnose chronic fatigue syndrome until we've got that out of the way. And that would apply also to a number of other psychiatric conditions, and I think we need to be attuned to that, but patients hate you wanting to treat them with depression because it's almost like they're straight away being labelled as a psychological nutcase or something like that. In fact, we're not labelling them that way. We're saying we've got to deal with this first. And I think you'll probably all agree that depression and anxiety aggravate every illness in the book. So we're looking at a diagnosis of exclusion. We try and categorise it into subcategories, which in the genetic studies have fitted the differences in the genes that are switched on. So we get those people whose illness might have started with glandular fever, and those whose illness might have started with meningitis, and those whose illness was of a very rheumatological nature, and so on. And you find that about 30% of the patients that you see, if you're working in this field, actually do turn out to have something else. And that something else may be some of those things I listed just a couple of minutes ago. And the symptoms people experience tend on the whole to mimic their original illness. So if their illness started, let's say, with a gastrointestinal infection, they will tend to get a lot of bowel and stomach problems. If their illness started with maybe viral meningitis, they will get far more in the way of headaches and cognitive problems and so on. And so what do we do about managing? And a lot of it is common sense stuff that would apply to almost any medical illness or health condition. First of all, of course, this correct diagnosis is absolutely mandatory, and most people nowadays, we find, you know, once you've made that diagnosis, they feel really relieved because they've often been the rounds of many doctors, psychologists, health practitioners, naturopaths and so on, and nobody's really been able to tell them what's wrong with them, and so they're feeling terribly ill a lot of the time, and they know that something's wrong, but nobody can tell them what. So correct diagnosis can be really therapeutic, and then you acknowledge support and help to educate both the person with the illness and their family and their employers and their school teachers and everyone around them. And the more you can educate those around them, the better they're going to cope with their illness, because having support people in your life is always going to be helpful. And then we look at all these various lifestyle things which I'll just buzz through, but certainly stress management, terribly important, And stress aggravates every illness in the book. So everything you can do to really help them acknowledge and walk away from stress sometimes, learn some really good relaxation skills, maybe have some counselling and cognitive behavioural therapy, but stress management really high on the agenda. And exercise. Now, exercise, most patients with this will cringe when you start talking about exercise because it really can aggravate their health if they don't do it right. And they've often learnt the hard way. There'll often be people who are trying to get back into life and they've always done exercise to get themselves fit again and suddenly they can't. And so it becomes very, very frustrating. And if they push the exercise too hard, almost invariably they will suffer from a relapse. So you get some people who are really ill down the bottom end who can barely walk to the loo, and you get people at the top end who are nearly better, and they are trying too hard and they're trying to get back into their sport and they're constantly relapsing. So you've got to get them to acknowledge where they're at on that spectrum and then stick to that level so that they might be able to walk up to the letterbox and get the mail, or they might be able to walk around the block with the dog, but they certainly can't do what would be construed as normal, but at least doing a little bit regularly, maybe 5 minutes twice a day or 2 minutes every hour, starting them off very minimally, can lead to overall improvement in their health and well-being. We call it pacing, not graded exercise that you build it up very rapidly and risk relapse, but a very slow, cautious paced approach. And they importantly don't sort of get to that point of being about 80% in health and then suddenly thinking, oh, I'm all right now, go and play tennis, go up there, crash right down again. You've got to be really, really aware of that risk. Nutrition, well, again, most of us know what we should and shouldn't be eating, but sometimes a bit of guidance is needed. And people generally don't benefit from any of these special expensive diets or new ideas that are out there. Many people will have tried anything and everything, but at the end of the day, there's nothing so good as sensible, balanced nutrition. And people generally with this illness do better with little regular meals rather than putting their stomach on a marathon run by having a huge, great meal which then can't be digested because the stomach seems to be just like the limbs. It can't cope with too much at once. Alcohol, caffeine, and foods that particularly are very rich or difficult to digest are better avoided, though people can tolerate tiny amounts, and some people like a cup of coffee to get them going in the morning, but if they're going to have caffeine, they should avoid it from about 2 p.m. onwards. A lot of people come to me and say, oh, you know, I've been told I must drink plenty. And fair enough, you need plenty, but not excess. And some people will be saying, oh, I'm drinking, 8 litres of water a day. And what they're doing is they're spending the day on the loo and washing all the goodness out of the system as well. So probably the 8 glasses of liquid a day is about right. And for this illness, it's one of the few illnesses that we look at extra salt, and I think we've all been brainwashed. I think we're going to die of a stroke tomorrow if we have too much. But in this illness, these patients generally, but not 100%, but generally have very low blood pressure. And because they've got low blood pressure, they're getting many symptoms, and the extra salt can increase their blood volume a little bit, and it puts the blood pressure up maybe 10 points if they're having enough. And they go from, let's say, 90/60 to 100/70, which is still a very, normal, acceptable blood pressure. They're not putting themselves at risk of stroke. And so the extra salt can lift some of the symptoms. And we're talking of something like a pinch of salt every 2 hours. And they can have it spread on the food or lick at it or have salty snacks or what have you. If they're having a lot of salt, they need to balance it with adequate potassium in the diet. Again, better to have it in the diet than as a supplement. and a banana or kiwi fruit a day is fine. And most people benefit from a bedtime snack. We're going to talk about sleep shortly, but snacking at bedtime does help improve the quality of the sleep for these patients. And sunshine you don't eat, but it's pretty obvious that we need it for vitamin D. And these patients seem to often be very low in vitamin D, possibly because they're not going outside much, but it's also thought the immune system uses up a lot of vitamin D. So they do need to make sure they have some time outside. And they don't need to be sunbathing in the nude. They need to be sitting outside for maybe 15, 20 minutes a day. Not today probably, but you know, the arms and the face uncovered, and trying to get that undiluted light. And when I say undiluted, not through a window. You don't get vitamin D properly metabolized through a window. You're better outside. And then everybody wants to know what supplements they should take, and most people have spent half their life savings trying anything and everything, and there's not an awful lot out there that's been proven to help this illness, but a few things to say. You absorb your supplements far better from food than from a handful of pills, and that's because as soon as you see some nice food on the plate, you begin to salivate, and salivation is part of the digestive process. You don't salivate when you see a handful of vitamin pills, so you're going to do better getting it that way. And we would use supplements if there were deficiencies in the blood, like a low iron in a menstruating woman, or low calcium because the person was off dairy products or something. And so if the blood or the diet was deficient, we would supplement appropriately, and sometimes to treat certain conditions, like we'd recommend folic acid for a pregnant woman to prevent neurotube defects and so on. But generally in this illness, there's very little that's going to do much good. But a few things that have been shown to be useful and little building blocks towards feeling a little bit better. And the omega-3 oils, this Professor Pure in London has shown that that can improve some of the brain symptoms in particular. B12 injections, people often, I think about 70% do benefit from B12 injections, not always brilliantly, but some people do very, very well on them. And this research has been done in particularly Iceland, and the B12 has been shown to be low in the cerebral spinal fluid in a number of these patients, and B12 by mouth, you don't absorb it terribly well, so giving it by injection, maybe weekly over 6 weeks, something like that, can have some benefit. Magnesium helps with relieving cramps and some of the fibromyalgia, particularly at night, and we absorb it better overnight. It's combined with malic acid in some of the tablets, making it very expensive. But malic acid is actually the main component of apple juice, so you really don't need to buy that combined expense if you have the magnesium with a swig of apple juice. Coenzyme Q10 shown to improve some of the muscle pain in some patients. And again, these often are very hard to measure effects, but they're worth doing. And the Japanese found this rather complex sugar called D-ribose, which you don't get in food, can improve energy, and we've already mentioned vitamin D. And the probably important one is to avoid too much vitamin C. A lot of people swallow endless amounts of vitamin C thinking it's going to fix everything. And there's been a lot of publicity about it, but in this illness it's likely to hype up the already hyped up immune system, so you don't want too much of it. Again, I haven't got time to go through all the medication in depth, but there's two important areas, or three, the top three important to talk about really. And just as a reminder, that's a normal sleep cycle. And people with this illness probably don't get enough of this deep level 4 sleep, and they may not even get enough of the REM, the dream sleep. And dream sleep restores your cognition and your mental processing, and in this level 4 sleep you're said to improve your immune system. It quietens down some of the abnormalities, and you produce all the hormones and chemicals that have healing effects on your body. That's simplifying what's a very complex process, but in this illness, you know, you're missing out on these vital areas. So sleep management's really important, and again, I'm not going to go through this whole lot, but sleep routine is obviously important, and I've already mentioned the snack at bedtime and the possibility of a magnesium supplement. But the tricyclics are probably the drug of choice in this illness, and some of the researchers I've met have gone so far as to say, if a person doesn't respond to a tricyclic with this illness, they may not even have the right diagnosis. It's that important to focus on. And the tricyclics are very old antidepressant drugs, of course, which are not used so much nowadays for depression, but in very, very small doses are very appropriate for sleep management. And important thing to remember is these patients are very, very sensitive to medication, and also everything's on go slow. So I've found in general taking a tricyclic about 5 hours before bedtime has the best effect, and it's absorbed slowly, but by the time they go to bed, let's say at 10 o'clock, having taken it at 5, they're ready to go into a sleep cycle which may be much more restorative and better than it had been. It takes about 2 weeks to work properly, and we usually start them at about 5 milligrams of something like nortriptyline or amitriptyline and build it up gradually, some people needing about 50 milligrams, some doing very well on 10. So that would be top of the list. And melatonin for those that have difficulty actually getting asleep, that can be useful, and one can do the combination. And the sedating antihistamines are very useful for people who have a lot of blocked nasal passages, allergy symptoms and so on, which again are very common in this illness. And you know, I'll often use the 3, but all in very, very tiny doses. These other drugs mentioned here might well be appropriate, but they're very much more for specialized sleep conditions, which often do go hand in hand with this illness. You might, for example, get someone with restless leg syndrome, and we would use the ropinirole, which does help that. Autonomic dysfunction, so-called orthostatic intolerance, we've already mentioned the salt, and they need to learn to get up slowly. They can wear support stockings. I've even had people in sort of elasticated bodysuits, which make them look like deep sea divers, but they will say they feel absolutely wonderful when they're wearing these things. And fludrocortisone is a drug which helps the body retain the salt better. So that is something we might move on to at the next level beyond the basic stuff. And some people do very well with a beta blocker. That's a bit of a, kind of unusual thing to say, because beta blockers will lower the blood pressure further. So they will get often a better heart rhythm though, which is often quite disturbed in this illness. But they're the ones that are going to need even more salt. So, you're kind of playing around a bit here and watching the blood pressure and symptoms very carefully. Pain control is really important because many of these patients have really serious problems with pain. And you've got all the simple everyday stuff like warmth and massage, and then using relaxation techniques. Hypnosis is valuable sometimes, acupuncture and so on. And most of the time people will have tried the simple analgesics like paracetamol, but not get much help from them. Anti-inflammatory drugs, again, being tried, not much help. And you move through the strong analgesics, opioids and what have you. And there's not a lot of benefit often from medication, though some people do actually respond to what I would call everyday stuff. Anti-epileptics, however, tend to be the mainstay of patients with this illness who have really severe pain. And I'm talking very severe pain quite often, that headaches that are almost overwhelming and almost constant, or muscle pain that really limits their ability to activate very much at all. And particularly the one we have here is gabapentin. The doctor has to apply to Pharmac for funding, but that's usually just a rubber stamp procedure. Pregabalin is similar, for some people a little better, but they do actually have to pay for it, and it's an expensive drug. The rheumatologists have looked at this so-called low-dose naltrexone. Naltrexone's a drug that's used to get people off things like heroin. These are not patients needing it for that reason at all, of course, and we're talking a mini dose. And the rheumatologists who have done some of this work, they did a pilot study, and bigger studies are going on now, have found that very low doses of naltrexone are valuable for people with fibromyalgia. Not all of them, but there's certainly a move towards using that. Again, it's simple and it's safe. We do need to treat the depression, anxiety. I've already mentioned that, and you go through the usual range of possibilities with counselling and various types of drugs, but particularly we're looking mainly at the SSRIs and the so-called SRNIs, and most patients can tolerate small doses building up very, very slowly. And I think that's the key, because with these patients, if you give them a normal therapeutic dose of something, they will often get such severe side effects that they just won't take it for more than 48 hours, and you've lost the battle. So you really need to start with the most small dose you can possibly get organised. And if you were using, for example, paroxetine, comes in a tablet, you can break it into 4, so they take about 5 milligrams to start with, which is a very, very tiny dose, and build it up slowly. A lot of talk around the world about whether we should use antimicrobials, be they antibiotics, antivirals, antifungals, and so on. Again, there's not a real place for this in a sort of what I would call unproven situation. But if you sense that a patient has some sort of background infection going on, which is perhaps keeping their illness alive, keeping their immune system hyped up, giving them symptoms, then you might well be considering something here. And particularly, I would say, this is one I would use, acyclovir. You get a lot of patients with this illness who have recurrent herpes infections, and that might be like a cold sore or genital herpes or herpes zoster, which of course is shingles. And patients will often say, well, I keep getting attacks of these things, and it may well be that that background herpes virus is what's keeping this whole thing going. And so therefore a long-term use of something like acyclovir can be really, really worthwhile. And when I say long-term, I would be using 400 milligrams twice a day over maybe a year. Very few patients actually do get any ill effects or side effects from it. Most of them tolerate it very well, which is interesting really, because again, these are patients who are quite sensitive. I mentioned oxymatrin down the bottom. This John Cheer's the one that talked about the enteroviruses in California. You may take yourself back 3/4 of an hour if your mind is still with me. And he talked about finding the enterovirus in the stomach, and there's not been a particular antiviral agent found against that, but this oxymatrin is a Chinese herb, and he found with much sort of struggling around the world trying to find something that could work, oxymatrin does actually have an effect on that particular group of viruses. Not a complete, flattening cure, but it flattens it enough to give the patient quite considerable relief from symptoms. It's now marketed in the States called Equilibrant. It's not terribly expensive, and people can get it sent in. They've got to go through all customs and everything. But he says you should only use it ideally in a proven situation. But if you have patients who have a lot of problems with gastrointestinal symptoms with this illness, it's very safe, something one can try, and it's a buy over the counter thing. It's not only a prescription item. And then estrogen is talked about quite a lot in relation to this illness, because the majority of women who become pregnant if they've got chronic fatigue syndrome actually improve enormously during the pregnancy, and many will say it was a turning point, and from then on they remained well. So the pregnancy effects are very worthwhile focusing on. So pregnancy is not a no-no, and it's probable that the estrogen improves brain blood flow, so they get better brain blood flow. It alters the immune system, so it improves the immune system, and so on. So there's definitely benefits for pregnancy for most women with this illness, but not absolutely all. There will be some who say they really couldn't cope with the pregnancy, and maybe they chose the wrong timing in some way. It's always hard to say. But however, one has to say that hormone replacement therapy and oral contraceptives are useful to try in the non-pregnant women with this illness, because that little boost of estrogen and keeping the estrogen levels fairly consistently flattened is very, very helpful for many women. And a lot of the research around the world, by particularly this Birgitta Evengard in Sweden, has shown that estrogen is a well worth trial for people with this condition. Immune modulators, they're drugs that improve the immune system in some way. Again, very much experimental. Where this one, rintatotolamide, been around for probably 15 years now. There have been endless trials in the States. They're never seeming to get there with it. However, it has been proven and shown to be very, very good for the very severe patients with this illness. But at $25,000 per patient per year, it's not something pharmac are going to fund here in a hurry, but it is a useful drug for those that are fortunate enough to be involved in the trials. Isoprenazine you can get here. Again, it quietens the immune system down in about 1 in 4 patients. But again, very expensive, $300 or more per month, and a lot of patients can't tolerate it, and it takes about 6 months before they start to see any improvement at all if they're going to. So again, not an ideal situation. I put the word immunizations there really as a reminder that people with this illness probably should avoid any unnecessary immunizations, because you do see relapses following immunizations, because there are going to be, again, changes in the immune system as a result. And so often I have seen people who've relapsed after a flu injection or relapsed after injections ready for going overseas. So they need to be very, very cautious about immunizations that they don't absolutely have to have. There's lots of research going on around, and Professor Tate here, I'm sure, has told you about his research, which is very exciting for us here in New Zealand. But there's lots of talk now too about whether this is in fact an autoimmune illness. The Norwegians have done a lot of early research looking at that issue, because they found that patients who were suffering from B-cell lymphoma, who happened to have chronic fatigue syndrome as well, this was a specific few patients they had that had both conditions, did very well on this drug called rituximab, which is a drug used in autoimmune illnesses. So there's a lot of research going on in that way. And Sonia Marshall-Grodisnik in the Gold Coast has got a really incredible facility there. They've got a purpose-built building for researching this illness with clinics and a wonderful setup. It's still in development stages. And Jonathan Kerr, who did the original gene studies about 7 or 8 years ago, has just got back into working in this field again. He's a researcher from London. So there's quite a lot going on, and the Japanese too are doing a lot of work. I won't talk about that for now. That's the book I produced, which is here, which is available if anybody wants and needs it. That's the booklet which you can get over there, which is, Heather has got copies and Debbie. This has been produced and just revamped its 2nd edition. And this has been produced by a group of physicians from around the world, and I was on that panel too. And we worked on it for about 2 years to produce a set of guidelines for clinicians. And it will be constantly upgraded on their website. And I think it's fair to finish off by saying that all these patients can experience better quality of life if you have compassion and a multidisciplinary approach. And they need to learn to feel in control of their health rather than the illness controlling them. So most people who come to you with this illness feel it's completely taken over their lives in every way, and it really has, and they need to be able to reverse that feeling. And I think by giving them some tools to work with, that's often what happens. And certainly going slow like the tortoise and going very slowly through every aspect of management and diagnosis and treatment, and then the patient running their life along that way seems to work. So that's where I will stop, but maybe there are 1 or 2 questions or comments that people would like to make. Any? Well, I think we are supposed to be finished by 12:55, so I'll just get Heather to maybe make a few comments. Heather is our local coordinator, do you describe yourself as, for the ME group here? She's also president of the National ME Association. And Heather works really, really hard in the background, keeping things together, and she's produced all this information today for us to give out to people, and also a sheet if you want further contact with the association.
I just so we've got information over there. There's pamphlets, there's doctor's booklets, there's a wee few of the PowerPoint that Ros has done. I'd also like to thank Ros for coming today, and the weather's been really cold and snowy, and it was quite a novelty to Ros, who's from Auckland, so of course you don't get much snow. So
no.
Just a little thank you for coming.
Thank
so,
you.
Yeah. Oh. Judy wants to take a photo.